So Dr. Bruttendu has not made to the conference yet, but I will be presenting his presentation. So this is tubercular uveitis, a great masquerader. Living in a highly endemic country with high tuberculosis load, we are always considering tuberculosis uveitis as a differential in all the cases, almost all the cases, whether it is anterior or pan uveitis. We are considering TB as one of the differentials. So this will be more of a presentation in which we are seeing the various phenotypes of the tubercular uveitis. So as I have highlighted, tuberculosis infection of eyes, it can present with various clinical signs and symptoms, and frequently it can mimic other ophthalmic diseases. The challenges in diagnosing ocular tuberculosis is that it can have varied clinical presentation. The quantity of specimens which we get from ocular samples is very less, and there are certain lack of laboratory investigations which will help us to say with extreme confidence that it is tuberculosis. And there is absence of uniformity of the diagnostic criteria for tubercular uveitis. So it can involve any part of the eye, right from the anterior chamber to the posterior chamber, in the form of anterior uveitis, intermediate uveitis, retinal vasculitis, and involvement of the choroid in form of choroiditis or granulomas. And in rare manifestations may involve endophthalmitis, panophthalmitis, hypopyon uveitis, or subretinal abscess. So moving on to this patient. So there are certain signs which can predict whether it is tubercular or not. So as we can see in this patient who had presented with a chronic anterior uveitis, there are multiple nodules and there are broad-based posterior synechiae. So this was a paper from PGI in early 2003, which says that if there are more of these broad-based posterior synechiae, we should consider this is a phenotypic sign, and we should consider that this may be a tubercular kind of a uveitis. In the second patient, we can see Basaka nodules, and also these nodules on the iris surface, and there are multifocal these mutton fat KPs, which again point towards a diagnosis of tuberculosis. In cases of acute miliary tuberculosis, there can be a severe anterior uveitis with the yellowish gray nodules all over the iris, and again in severe cases there may be presence of a hypopyon. This is one of a rare involvement of the anterior chamber in which there was raised IOP, solar lens, and this was followed by a scleral abscess. So it can also involve the sclera in some of the cases. So this is one of the patient who presented with a disc edema. There was presence of vitritis. So FFA reveals that there is presence of a hot disc, and there is this peripheral vascular leakage. OCT also helps in the diagnosis, as we can document CME, and this is a case of intermediate uveitis. The CT as well as MONT2 came out positive for this patient. Again, there can be involvement of the retinal vessels also in tubercular uveitis. In this patient, we can see that there was presence of vitreous cells 1+, and there was typical this perivascular involvement of the vessels. In case of tubercular panuveitis, tubercular vasculitis, we can see that there will be more of a involvement of the veins, and multiple hemorrhages can be seen in tubercular etiology. Also on FFA, it has been seen that in these kind of patients there can be extensive neovascularization and non-perfusion of the periphery. Moving on to tubercular choroiditis, a recent this COTS is doing a great work in having to reach certain consensus regarding the diagnosis of tubercular choroiditis also. So they have seen that almost any kind of a posterior kind of involvement can be seen in case of tuberculosis in the form of a SLC, multifocal choroiditis, MPGNS, and even MP-like picture can be seen in case of patients with tuberculosis. So this is one of the patient in which different type of phenotypes of tuberculosis can be seen. In one eye, he is having a multifocal choroiditis type of a picture, and in the other eye there is serpiginous like of a picture. Moving on to the these multibacillary type of involvement, there are two types of diseases in tubercular uveitis. Either it can be a paucibacillary, which is the earlier part which has discussed, and in the multibacillary type of involvement, these granulomas are common. So granulomas in case of tuberculosis are having these a typical deep pattern, deep involvement. They may be involved. There may be some hemorrhages along the borders of these granulomas. Also in FFA, initially we can see that there will be a presence of this hypo pattern along with the this hyper along the borders of the lesions. In extreme cases, in cases of patients who are immunosuppressed or patients who have this kind of a disseminated TB, subretinal abscesses can also occur. This is due to the rapid multiplication of the bacilli, and frequent, this can be associated with large exudative retinal detachments also, as was shown by this paper from South India. So a few of the rare presentations are neuroretinitis can also occur in the form of a macular scar formation, and tubercular optic neuropathy can also occur in these kind of patients. Again, endophthalmitis and panophthalmitis are also very rare presentations of intraocular tuberculosis, and in these kinds of patients, these will be associated with some kind of a hypopyon or a subretinal abscess formation, as Dr. Anirudh sir had shown one of the case. So I will, most of the patients have been taken from our mentors at PGI Chandigarh. I thank you for your patient listening.